So we're continuing our fellows series today. You guys, fellows, are you all registered for the SNS conference in Cleveland next week? Yep. Okay. Um, so I would for sure attend Friday. Saturday looks like there's some good topics. If you're available to attend, I'd encourage you to attend. I know from the attending's perspective, a lot of us have conflicts, but if you guys have the availability to attend, I'd encourage you to attend. So we will not have lecture next Friday, as you guys probably already know. We'll be downtown. All right. So Janine's taking over and doing nephrology and urology. Did anybody attend the fellows CAQ review at AMSSM?
Yeah, me and Heather did.
Did they talk at all about the new blueprint for the test?
No, they just kind of went directly into the topics.
So I watched the digital version of the fellows forum on the program director side, and like the new blueprint, they've pretty much said it's just going to be a lot more clinical, and it sounds like they're cutting out a lot of like the basic biology and physiology stuff, which is good. Um, so I'm hoping like by covering a lot of these, straightforward topics, it says it's the test is going to be geared much more towards like what we do every day as opposed to all of the basic science stuff. So hopefully, although I would tell you, I don't feel like I had a ton of basic science on my test. I've probably just blocked it out. I felt like mine was pretty heavy clinical. So hopefully, topics like this will be high yield for you all. All right, take it away.
All right, so today I'm going to be talking about sports nephrology and urology. Oop, Here we go. So this is the objectives of my talk today. I'm going to briefly go over some renal anatomy and physiology, and then I'll kind of go into each of these topics and hopefully just hit kind of the high yield aspects of each that are going to be relevant for the CAQ. So first, the kidney is a retroperitoneal organ. It's comprised of 1 million nephrons per kidney, and it receives about 20% of the body's cardiac output. So as you can imagine, there's a really high metabolic and filtration demand on the kidney. It's also one of the most highly perfused organs in the body and super important in handling certain solutes such as sodium, potassium, and glucose as well. Kidney is also the principal organ for maintaining water homeostasis. It filters a large volume per day. It's about 180 liters of fluid per day, and it resorbs about 99% of filtered water to match output with intake. Just wanted to discuss a little bit the effects of exercise on renal function. Like I mentioned, the kidney is a very highly perfused organ. The renal blood flow at rest is about 1,200 milliliters per minute. And with strenuous exercise, that's actually going to decrease to about 25 to 30% that of resting. And the reason for this is during physical activity, there's sympathetic activation and catecholamine release, and that's going to redirect blood flow from non-essential organs to the exercising muscle. Similarly, with renal vascular resistance, it's low at rest, but it markedly increases with exercise, kind of similarly due to that sympathetic activation and vasoconstriction. And then GFR, that remains mostly the same. It can be variable. It might decrease, but largely is maintained. And then for urine output, that's going to decrease during exercise, primarily to conserve water and to maintain circulatory stability. And then urine concentration is going to concentrate significantly to conserve water as well. So the first topic I'll talk about is exertional rhabdomyolysis. This is a clinical condition caused by repetitive exercise resulting in striated muscle breakdown, cell death, and potentially fatal complications, including renal failure and arrhythmia. The pathophysiology of rhabdo is similar regardless of what the cause is. So whether it's a direct cause or indirect cause, what occurs is that there is a depletion of ATP, and that loss of ATP causes dysfunction in certain ATPase pumps, and that's going to lead to an increase in intracellular calcium. And with that, there's going to be activation of certain proteases and nucleases, which are going to produce reactive oxygen species. And that's eventually going to culminate into the death of skeletal muscle cells. And then necrosis of the skeletal muscle cells are going to release intracellular contents, which are going to cause symptoms such as pain, swelling, and potential end organ damage in the athlete. So moving on to risk factors. Risk factors for increasing your risk for developing exertional rhabdo include things like athletes that are new to strength training. So the actual greatest risk for individuals are athletes with or people with low premorbid physical fitness, um, or even prolonged sedentary periods as well. The type of exercise also matters. So eccentric muscle contractions are going to cause greater mechanical disruption than concentric exercises. So things like downhill running, squats, and plyometrics can increase your risk. Also, sustained maximal intensity of exercise as well. So having exercise or increasing exercise intensity is actually going to matter more than duration or volume of your exercise. Environmental conditions, so high ambient temperatures and humidity are going to limit your heat dissipation. And so that's going to increase your risk significantly. Age, sex, race, and ethnicity also play a role, as well as certain genetic conditions like sickle cell traits. There are several medications that can increase your risk, but just to name a few, like NSAIDs, SSRIs, statins, and antipsychotics can all increase your risk. And then just looking over some of the herbal or some of the supplements that can increase your risk as well, black cohosh, herbal supplements, and even caffeine. There was at one time concern that creatine might increase your risk as well, but there's a recent study that showed there was no association. And then infection can also increase your risk. And then I included this news clipping here. I don't know if you guys remember last year, but there was a Navy SEAL that ran a workout for the Tufts men's lacrosse team, and it landed 9 players in the hospital with exertional rhabdomyolysis. I think if I were to guess, it was likely the type of exercise. They were rumored to have done hundreds of burpees. Also, the environmental conditions probably played a role. And there was also rumored to be no proper acclimation to this exercises into the workout. But this is just a real life example of exertional rhabdo. All these players ended up doing well and they recovered just fine. Clinical presentation, there's a classic triad, myalgias, generalized weakness, and tea-colored urine. Other symptoms you can have are fatigue, nausea, vomiting, and fever. For the diagnosis, you'll typically see an elevated CK. There's not a specific range for diagnosis of rhabdo, but typically greater than 5 times the upper limit of normal you'll see is more diagnostic. And then you're also going to see an elevated myoglobin. Um, and this occurs as a result of muscle breakdown, and then myoglobin is going to be excreted in the urine. So a urine level is going to be more specific than a serum level. And then you can also see some electrolyte abnormalities depending on what stage you are in the disease. So early stages, you can see hypokalemia, hypocalcemia, and hyponatremia. Whereas later on in the disease, you can see hyperkalemia, hypercalcemia, and hyperphosphatemia. For treatment, that's going to be aggressive hydration with normal saline. You want to try to meet a goal of 200 to 300 cc's per hour. Just a note on bicarb. It was previously used to alkalinize the urine and raise the pH above 6.5, and this was thought to prevent AKI. However, there's not really been shown to be a clear benefit, so just to keep that in mind. Also, diuretics, if you're not meeting your urine output goal, they can transiently increase your urine output, but actually causes intravascular volume contraction, which can actually worsen kidney function as well. Keep also to keep that in mind. And then for renal replacement therapy, it's far less common for exertional rhabdomyolysis, but you think about this when there's little to no urine output, a profound acidosis, or severe hyperkalemia, or even uremic complications. And then lastly, you want to consider inpatient versus outpatient treatment. So for inpatient, this is for more severe features and complications. So if you have an excessive CK elevation, any electrolyte abnormalities, or even compartment syndrome. And then for outpatient management, typically the athletes have milder symptoms, benign lab findings, and typically you want to closely follow them up. For prognosis, this is really going to be dependent on severity, but generally, exertional rhabdomyolysis has an excellent prognosis. There's a far lower risk of needing to proceed to renal replacement therapy or even death in exertional rhabdo, especially when compared to the other causes of rhabdo. Complications include AKI, compartment syndrome, cardiac arrhythmias, or even DIC. And then for return to play, There's a graduated progression to activity that's very similar to most return to play protocols. You kind of start off with your ADLs and progress gradually, ultimately getting up to the resistance training, agility, and running. And typically at that point, you want to see that the CK is downtrending appropriately, their symptoms are resolving, and they're no longer excreting myoglobin in their urine. And then for prevention, it's really just going to focus on acclimation and exercise progression. The next thing I'll talk about are urine markers, so hematuria and proteinuria specifically. So hematuria, this is when there's RBCs in the urine, greater than 2 RBCs per high-powered field in centrifused urine. Urine dipstick is going to be really sensitive for this. It can detect 1 to 2 cells per high-powered field. Hematuria arises from the disruption of vascular integrity anywhere along the urinary tract. So it can come from glomerular capillaries or even from the urethral mucosa. But pathophysiology is going to vary depending on what the anatomical source is. Glomerular bleeding reflects filtration barrier dysfunction, and then non-glomerular bleeding is going to stem from mucosal erosion, vascular malformation, or even neoplastic invasion. And then asymptomatic hematuria is going to be present in 5 to 6% of the entire population. And a large portion of children and adults actually have no identifiable cause of the hematuria. Hematuria can have several causes. That includes trauma, can be exercise-induced, drugs, UTI, urinary tract calculi, which I'll talk a little bit about later, and hematologic disease, structural disease, and immunologic disease as well. Specifically for exercise-induced, this is typically benign and transient, and there's a really high prevalence in endurance sports due to a phenomenon called foot strike hemolysis. So this is when there's repeated foot strike against a hard surface, and that's going to cause intravascular hemolysis of erythrocytes in the capillaries of the soles of the feet. And then that's going to release hemoglobin that precipitates in renal tubules and then ultimately gets excreted in the urine. For diagnosis, dipstick is really highly sensitive, but typically you want to repeat the UA with a microscopy to confirm the hematuria. You can also check serum creatinine and blood pressure measurement, and that's going to be important for helping to identify any underlying kidney pathology. You can also check a urine culture to see if an infection is suspected. And then with the microscopy, after you confirm, you want to risk stratify based on the RBCs per high power field, and that's going to dictate what your further workup may be. So if you have 3 to 10 RBCs per high powered field, typically you want to repeat the UA in about 6 months. If you have 11 to 25 RBCs per high powered field, typically you go for cystoscopy and then renal bladder ultrasound. And if you have greater than 25 RBCs, typically this is for cystoscopy and then CT urography, and that's to assess for any upper tract disease. And then the treatment is going to be dependent on the cause, but for exercise-induced hematuria, what you're going to have the athlete do is discontinue their exercise, and then you want to repeat the UA in 48 to 72 hours. If the hematuria is persistent, that might require or warrant further workup. Moving on to proteinuria. So this is defined as a urine protein excretion exceeding 300 milligrams per 24 hours, or a urine protein to creatinine ratio greater than 0.3. Adults typically secrete about 150 to 200 milligrams of protein in the urine daily, and the urine protein content is comprised of albumin, serum globulins, and then also tissue proteins. And then just to go over the different categories of proteinuria, I'll just kind of go over this chart to the right. There's glomerular, which is the mechanism for this is there's an increased glomerular filtration barrier permeability. This is going to have albumin predominant proteins in the urine, and it's caused by things like diabetic kidney disease and certain nephropathies. There's also tubular, which has an impaired proximal tubular resorption of filtered proteins, and you're going to see low molecular weight proteins predominantly in the urine. And things that cause this are acute tubular injury, interstitial nephritis, or even drug-related tubular injury. And then you can also see overflow. This is when there's an excess in circulating small proteins that can overwhelm tubular reabsorption. Typically with this, you'll see non-albumin proteins that are predominant. Causes of this include multiple myeloma, where you'll see the light chains, rhabdomyolysis, where you'll see the myoglobin, and hemolysis, where you'll see hemoglobin. And then lastly, there's post-renal. This is when there's protein added to the distal kidney from inflammation, infection, or even bleeding. The urine protein, typically it's mixed, but it's often non-albumin. And you can see this with UTIs, stones, or even bleeding. And then transient proteinuria can be seen in pregnancy, fever, stress, or even exercise. So for exercise-induced proteinuria, this is common. It's benign and it's transient. It lasts only about 24 to 48 hours. It's related to exercise intensity rather than the duration. And the proposed pathophysiology for this, it's thought to occur because exercise increases filtration in the kidneys and may temporarily raise glomerular permeability. And this could possibly be due to lactate buildup and a drop in pH. It doesn't appear to resolve with regular conditioning, and it also is biphasic. So there's an early phase about 30 minutes after exercise, and that's related to hemodynamic changes and tubular saturation. And then a later phase around 24 hours due to oxidative stress, when albumin alone can be excreted. For diagnosis, you're going to check with a urine dipstick. And then treatment, similar to exercise-induced hematuria, you're going to have the athlete stop exercise and then repeat the dipstick about 48 to 72 hours after discontinuing exercise. And if the proteinuria is persistent, a further workup might be warranted at that time. Next thing I'll talk about is nephrolithiasis. So this is really common. Kidney stones are really common. About 8 in 1,000 adults have them, and then 1 in 11 adults will experience kidney stones in their lifetime. So for characterization of the kidney stones, they can be calcium, which is the predominant type, uric acid, struvite, and cysteine. So calcium, oxalate, and phosphate together make up 80 to 90% of kidney stones. Um, there are certain medications that are associated with an increased risk, so high dose corticosteroids, certain vitamins, and also carbonic anhydrase inhibitors. And then there's also a dietary risk as well. So if you have or are eating a high sodium diet, low potassium diet, a low or excessive calcium intake, so there's kind of a sweet spot of how much calcium you should be consuming daily to decrease your risk. And then high protein diets also increase your risk. Low fluid intake as well as excess caffeine intake can also increase your risk. For diagnosis, typically you want to get a UA. So hematuria is going to be present in 70 to 90% of symptomatic cases. And then you can check a urine culture as well to evaluate for any underlying infection. In terms of imaging, non-contrast CT of the abdomen and pelvis is going to be your best test. It's the most sensitive and specific. However, you can consider an ultrasound, especially in the acute setting, but it's going to be less sensitive and specific for this. And then you want to identify any causative factors. So the risk of recurrence of kidney stones is really substantial. It can be up to 50% at 10 years. So finding any modifiable risk factors is going to be essential. You can do stone analysis, especially if you have a stone available. For non-calcium oxalate stones, that's going to require additional workup. So if it's comprised of cysteine, uric acid, or struvite stones. And then you want to assess for volume status and dietary factors of the patient as well. And then the kidney stones, they could require extensive workup and metabolic evaluation, just kind of the labs that I listed below for that workup. But for a high risk patient, so for a patient that has maybe a family history or a childhood onset, a solitary kidney, or even renal insufficiency, those are kind of the high risk patients, or even with recurrent stones, so greater than 2 stones, or 1 stone with a high recurrence risk, for all to consider a more comprehensive workup for those. For treatment, typically is pain management with NSAIDs. Ketorolac is kind of the mainstay that we use a lot in training. And then you also want to maintain hydration. For fluid intake, you want to target a urine volume of greater than 2.5 liters per day. And then to talk a little bit about dietary changes, which are going to be important in treatment and in prevention, but you want to typically limit your sodium intake to less than 2.3 grams per day. For dietary calcium, you kind of want to maintain that sweet spot of 1 to 1.2 grams per day, and you don't want to restrict calcium excessively. You also want to limit oxalate-rich foods, so things like spinach, nuts, tea, and beets. And then just a note on medical expulsive therapy. So these alpha blockers, tamsulosin and doxazosin, which we typically see used in things like BPH, but they're very good for stones that are less than 10 millimeters in size, and then also stones that are located in in the distal ureter. So their mechanism of action is that they're alpha blockers, and these alpha 1 adrenergic receptors are located at the distal ureter. And so they're going to relax the smooth muscle, reduce peristalsis, and then also decrease intraluminal pressure around the stone to help expel the stone. And then for surgical intervention, typically if the stone is less than 5 millimeters, it's going to pass spontaneously, but stones that are greater than 10 millimeters will rarely pass. So things like shockwave lithotripsy and then ureteroscopy for stones greater than 20 millimeters, and then percutaneous nephrolithotomy are all things you can consider. And then for prevention, like I mentioned, there's a lot of lifestyle modifications you can make, including increasing your fluids, decreasing caffeine and carbonated drinks, increasing fiber, decreasing sodium and potassium or protein, and then also optimizing your calcium intake. You can also consider citrate supplementation. This can be good for calcium, uric acid, and cysteine stones. And then certain medications that you can consider. So thiazide diuretics like chlorthalidone, 25 milligrams daily. This is good for patients that have hypercalciuria. And then allopurinol, you can also consider 300 milligrams daily for the uricosuric calcium oxalate stones that have normal urinary calcium. Next thing I'll talk about is pudendal nerve injury. So pudendal nerve injury encompasses a spectrum from acute traumatic or iatrogenic damage to chronic entrapment syndrome, such as pudendal neuralgia. The pudendal nerve arises from the somatic nerve branch from sacral plexus, S2 to S4. It's responsible for the sensation of the external genitalia, the skin around the anus, and the perineum. And then it's responsible for motor control of the pelvic floor muscles and the perineum, the external anal sphincter, and then the external urethral sphincter. So if you see these diagrams down below, you can kind of see S2 to S4 kind of converge to make the pudendal nerve. And then the diagram to the right, you can kind of see the pudendal canal. And then bicycle riding is going to be a very common cause of this, especially with hard, narrow saddles. This is going to cause compression at the ischial spine and pudendal canal interface. There are common points for nerve compression, and there are proximally between the sacrospinal and sacrotubus ligaments due to stretching with pedaling, and then also increased friction with pudendal canal from the saddle pressure, and then also at the anterior pelvic ring by the nose of the bicycle saddle. And then this is actually really common in cyclists. There's a lifetime prevalence of 50 to 90%. And then the incidence is going to increase with age, increased body weight, and cycling time. And then you have an increased risk of recurrence if you're cycling more than 3 hours per week for more than 10 years. Presentation, you're going to see pelvic pain, numbness, and tingling of the genitals, frequent urination, a reduced sensation of defecation, and even partial erectile dysfunction. Treatment is going to be really simple. You just tell the athlete to stop riding until the numbness resolves, and typically it's going to resolve pretty quickly. It's rare for it to last several weeks. You can also look at the biomechanical analysis of the cycling seat to kind of optimize the positioning of the saddle and to decrease your overall risk of recurrence. Then you can consider something like ultrasound guided nerve block, which is far less common for if you know that the cause is due to cycling. But if it's, you can consider this if the patient has very persistent symptoms. Next, we'll talk about scrotal trauma. So sporting is a common cause of scrotal injury in adults and children. There's over 15,000 sports-related GU/ED visits in the US annually. A third of that are cyclists, and 75% of them are seen in peds. It can be caused by a penetrating trauma or a crush injury. That's when there's compression of the testicle against the pubic arch and an impacting object. And then it can be caused by blunt trauma as well. Over 85% of testicular injuries are going to be due to blunt trauma. So sub-Q hematoma, hematocele, epididymis, spermatic cord compression, or even direct testicular injury. So there are different types of direct testicular injury. So first, there's testicular rupture. This is when there's tearing of the tunica albuginea with extrusion of the testicular parenchyma into the scrotal sac. This is associated with testicular laceration, fragmentation, intratesticular hematoma, or infarction. And then for this, surgical exploration is going to be warranted if testicular injury is suspected. And then the testicle is salvaged in 90% of patients if it's repaired within 72 hours. For testicular contusion, this is when there's an intraparenchymal hemorrhage without any tunica albuginea disruption. And so this is typically managed conservatively with serial ultrasound. And then testicular dislocation is when there's displacement into the inguinal, perineal, or femoral regions, and that's going to require manual reduction or surgical fixation. And then traumatic testicular torsion, I'll go into a little bit more detail a little later. For physical exam, this is often limited by pain, although a physical exam is going to be really important because it provides immediate feedback that can identify time-critical conditions, and then it can help determine the need for a surgical intervention or even further imaging. Also, the GU tract is seldom injured in isolation, so doing a thorough physical exam to assess for other injuries is important as well. You'll also see scrotal swelling and ecchymosis, and that's the most common finding. However, the degree of scrotal hematoma doesn't necessarily correlate with the severity of the testis injury. For imaging, ultrasound of the scrotum is going to be rapid and non-invasive, and it can actually decrease the need for surgery in certain mild trauma cases. And then it also has a high sensitivity for testicular rupture and avulsion. For management, penetrating injuries require surgical exploration in the majority of cases. Testicular rupture, large hematoceles, traumatic torsion, and dislocations are all going to require surgery. And then for testicular contusions, these can often be managed conservatively with bed rest and analgesics. For prevention, and then just a note on athletes with a solitary testicle. The National Athletic Equipment Committee doesn't necessarily make specific recommendations for genital protective gear, but an athletic cup might make sense for collision and projectile sports such as football and baseball. And then for athletes with a solitary testicle, the AAP supports unrestricted sports participation for athletes with a single testicle or an undescended testicle, but they do recommend protective gear in high-risk sports. Next, I'll talk about testicular torsion. So this is the most common cause of acute testicular pain and testicular loss in adolescence. The incidence may be as high as 1 in 160 males, with a peak prevalence around the age of 14. Two-thirds of cases occur between the ages of 10 and 20, and it's really rare to occur after the age of 30. And most cases are actually idiopathic, with only 4 to 8% that are a result of trauma. And then with a torus testicle, they typically torus lateral to medial, so internal twisting, and that's going to be important when we talk about management a little bit later.
And this is like one of those topics, I don't know why, but on CAQ, there's always a torsion question. So they love to ask about it.
Okay. Clinical presentation and physical exam. Typically, you can have acute and then subacute presentations, but for acute, there's sudden onset unilateral testicular pain and tenderness, and for subacute presentations, there's typically scrotal erythema and edema. For acute torsions, they involve a complete arterial and venous obstruction, and there's going to be, again, severe pain with sudden onset, whereas with subacute torsions, that encompasses more of those incomplete torsions or intermittent torsion or delayed presentation, and they have periods of reduced pain. On exam, you'll see a swollen, firm, and tender testicle. You'll also see an asymmetrical high riding testicle with a bell clapper deformity, and then also loss of the cremasteric reflex. This is a clinical diagnosis, but it is a surgical emergency. Imaging might assist in diagnosis, but really shouldn't delay the surgery. Color Doppler ultrasound is going to be highly sensitive and specific. However, surgical exploration is going to be indicated even if you have a negative ultrasound, if your clinical suspicion remains high. And then radionuclide testicular scintigraphy. This is also a highly sensitive and specific test. It assesses for testicular perfusion. However, it's more time consuming and not available at all institutions. And then for treatment, Manual reduction can be attempted first if a surgical service is not immediately available in order to alleviate pain, but it should not delay surgery. It's very variable if manual reduction is successful. There's a large range between 26 and 80% of cases are successful. Two-thirds of torsions are rotated medially, so you want to attempt a lateral reduction first. And then even if you are successful in manually reducing the torus testicle, a surgery is still going to be required. For surgical intervention, time is testicle, so less than 6 hours. The testicle is about 90% salvageable. If it's been greater than 24 hours, it's nearly 0% salvageable. And then emergent surgical exploration and fixation orchiopexy to the affected and the contralateral side is going to be indicated to prevent a recurrence. All right, so I'll talk about urethral trauma next. This is actually really rare in females. It most commonly affects males kind of due to the anatomy, but the majority are due to blunt trauma, including pelvic fractures. There's two different types. There's anterior urethral injury and posterior injury. So for anterior, there's injury to the penile or bulbar urethra, and this is typically due to a straddle injury. This is managed with a suprapubic catheter drainage with delayed urethral reconstruction. And then for posterior urethral injury, this is injury to the membranous or the prostatic urethra, and that's associated with pelvic fractures usually. And then these typically are complete injuries that require surgery. Posterior injury can lead to substantial long-term morbidities, including stricture, erectile dysfunction, even incontinence. And there's a much higher rate of complete disruption with posterior versus anterior. Clinical presentation, there's a classic triad of blood at the urethral meatus, soft tissue swelling, and also the inability to urinate. You can see a high-riding prostate on digital rectal exam, but that's not super reliable. For imaging, you want to consider retrograde urethrogram, which is the gold standard test. However, it doesn't reliably assess posterior injuries. Also, it's also indicated if urethral integrity is uncertain or if a bladder injury is suspected. And you typically want to do this before Foley placement to avoid exacerbating the injury. And then prognosis is going to depend on the location and severity of the injury, with posterior injury developing stricture in 90% of cases. However, definite urethroplasty does achieve 85 to 98% long-term success. And then the last topic I'll talk about today is renal trauma. So this is when there's injury to the parenchyma or renal vessels, and causes bleeding or injury to the urinary system with extravasation. The kidney is the most commonly injured GU organ, and then children are more susceptible to renal trauma than adults for several reasons. They have decreased perirenal fat. They have a larger proportional size of their kidney versus the rest of their body, and then also they have a lack of complete rib protection. For etiology, it could be due to penetrating injuries or even blunt, so things like MVC, falls, sports. Specifically for sports, the main mechanism for sports-related renal injury is going to be a solitary blow to the flank. This often occurs in isolation. There are certain high-risk sports, so contact sports are high risk. Skiing and snowboarding are also very high risk. Clinical presentation, typically if there's a suspicious mechanism coupled with flank pain, you'll see gross hematuria. This is more common with blunt traumas. And then sometimes you can see hypotension, but this is only going to be present in severe injuries. Diagnosis. So in the cases that you have hemodynamic instability with high suspicion for a renal injury, you're going to go for a surgical exploration. And then in terms of imaging, there are certain clinical features that are going to prompt immediate imaging. So if there's a penetrating trauma in the proximity of the kidneys, that would indicate imaging. If there is a blunt abdominal trauma and gross hematuria, that would indicate imaging. If there is blunt abdominal trauma with microscopic hematuria and hemodynamic instability, and then or just with a highly suspicious mechanism. The gold standard imaging test is going to be CT pyelography. This detects subcapsular hematomas, perirenal hematomas, and parenchymal lacerations. And then if there's persistent or recurrent hematuria beyond 2 to 4 weeks after injury, this is going to warrant a repeat CT scan. And just to go over the grading of renal injury, it goes from grade 1 to grade 5, kind of increasing in severity as you go. But for grade 1, this is a contusion, subcapsular hematoma without any parenchymal laceration. For grade 2, there's non-expanding perirenal hematoma with a less than 1 centimeter cortical laceration without urinary extravasation. And then grade 3, there's a greater than 1 centimeter cortical laceration without collecting system rupture. And then typically with grades 1 through 3, you're going to have better outcomes and lower nephrectomy rates. And then grade 4, you'll see a laceration through the cortex, medulla, and the collecting system, or you're going to see main renal artery and vein injury with a contained hemorrhage. And then grade 5 is a completely shattered kidney with loss of parenchymal anatomy or an avulsion of the renal hilum that devascularizes the kidney. And then my last slide. For treatment, grades 1 to 3 can usually be managed non-operatively. Grades 4 to 5, we typically manage these surgically. You can try managing them non-operatively if the patient is stable. And then most sports-related renal injuries are contusions, and those can be managed conservatively as well. Return to play for contusions are going to be highly variable, dependent on the athlete. But typically, you hold the athlete out for a couple weeks, up to 6. And that's going to depend on the severity of the injury. And then you want to check for resolution of symptoms. If imaging was indicated initially, you want to make sure the imaging is stable, and you also want to make sure there's no more hematuria before they return to play. And then for a renal laceration or diastasis, you might have a delayed return to play for this up to 6 to 12 months, given the severity. And then just a note on athletes that have a solitary kidney. There's no strong evidence that supports mandatory exclusion from contact sports. The AAP does emphasize informed consent and protective equipment rather than absolute restriction. So there's going to be a conversation between, the physician, the parent, and the athlete to decide whether or not it's safe to participate in a sport. But protective equipment that you can consider are a flak jacket, pictured at the top right. Although I've never seen any athlete wear this before. And
So you can also just do other padding. So
Mhm.
there's a lot of times we'll put people in like the sports specific rib padding more than that.
Okay.
So that's like a military flak jacket, but there's a lot of like sports specific like rib pads that we'll end
Mhm.
up putting people in.
Okay. Yep. And that's all I had for you guys. These are my references. That's my daughter.
Adorable. Yeah, lots of high level CAQ stuff there.
Great job, Janine. That was well done.
Thank you.
Yeah, good looking slides. Nice presentation. Will you send me your slides when you have a chance?
Yeah, absolutely.
Anybody with any questions? All right, everybody, go enjoy your Friday.
All right. Thanks, guys.
Thanks, Janine. Thanks. Bye.